Hello, my name is Kevin Fernando and I'm a GP partner at North Berwick Health Centre near Edinburgh, as well as Education Director for GPnotebook Education. We continue to work in very challenging times and there remains considerable uncertainty about how to support and advise individuals with significant comorbidities or on certain medications about their risk of COVID-19 infection. In this brief podcast, I'm going to discuss some helpful guidance from the British Society of Rheumatology, the BSR, including a risk stratification tool and scoring grid, which will help us in primary care advise individuals with rheumatological conditions and on immunosuppressive medications whether to shield or to maintain social distancing measures. Now, the government advised that people on immunosuppressive therapies, which are sufficient to significantly increase the risk of infection, fall into an extremely vulnerable group and should shield. This BSR guidance provides more specific advice in relation to those individuals at risk. It's well worth downloading or printing out the risk stratification tool and scoring grid, which I've found really helpful in primary care. Now, patients we should advise to shield include those on 20 milligrams of prednisolone or equivalent daily for more than 4 weeks, or those individuals on 5 milligrams of prednisolone or equivalent daily for more than 4 weeks in combination with at least one other immunosuppressive medication, such as methotrexate, azathioprine, etanercept, or infliximab. Helpfully, the BSR tells us those on hydroxychloroquine or sulfasalazine, either alone or in combination, do not need to shield and instead can maintain social distancing measures or self-isolate at their own discretion. The associated scoring grid is really helpful when working through our long lists of patients on DMARDs to update key information summaries and advise on what precautions to take. Patients we advise to practice shielding should be directed to Public Health England's guidance on shielding. For other individuals asking what precautions they should take, we can refer them to the Versus Arthritis website and COVID-19 patient information. Remember that some of our patients will have their immunosuppressive drugs issued by our secondary care colleagues, so this may not immediately be flagged up in our clinical records. For example, I have a patient with psoriatic arthropathy who receives adalimumab from the rheumatologist. I need to record this in the clinical records as a hospital prescription, and also I should read code that the patient is on a biologic, read code #8BCE. Also, I need to update the key information summary or any special notes to highlight this DMARD therapy. And also, I am now recording the BSR risk stratification score and any precautions I advise. Now, other questions usefully answered in the BSR guidance. Should patients cease their DMARD medication as a precaution against COVID-19 infection? The answer is a clear no here. All those patients aged 16 years and over should continue to take their DMARD therapy unless otherwise directed by their rheumatology team. If people do develop any signs of infection, then we should continue current practice and temporarily stop immunosuppressive therapy for the duration of that illness and until well again. Specifically, those individuals on long-term steroids should not stop their steroids abruptly due to the risk of adrenal suppression. Additionally, there has been some controversy about steroid use and adverse COVID-19 outcomes, and currently the BSR are not advising patients to increase steroid doses if they become unwell, which is in conflict with the usual practice of doubling steroid doses in acute illness. It's well worth cascading this message to our primary care colleagues. What about injecting steroids during this COVID-19 pandemic for rheumatological conditions, either intramuscularly or intra-articularly? Well, again, consistent with current practice, we should not inject steroids in the presence of any active infection. However, again, because of this controversy about possible adverse effects of steroids and COVID-19 outcomes, the BSR recommends we use our clinical judgment and consider whether the injection is needed now to keep a person mobile and independent, or if it can be delayed until the risk of COVID-19 decreases. What about other forms of analgesia then? Well, there's unfortunately also been some concern, some controversy about the use of NSAIDs and adverse COVID-19 outcomes. We have no conclusive evidence to date, but for now, the BSR recommend using paracetamol in preference to NSAIDs for analgesia. That said, those currently on regular NSAIDs do not need to stop them. Finally, what about frequency of blood testing for those stable patients on DMARDs? This has caused a great deal of concern in primary care. The BSR suggests it is usually safe to reduce blood testing frequency to 3 monthly intervals or even less in stable patients. However, we need to review cases on an individual basis and weigh up the risks of continuing without blood testing compared to the benefit of staying on DMARDs. It would be prudent to record any decision on frequency of blood testing in special notes too. Now, all of this BSR guidance I've discussed in this podcast, in addition to the risk stratification tool and scoring grid, can be accessed at www.rheumatology.org.uk. So thanks again for listening, everyone, and please stay safe and stay strong.